Welcome to Queen's West Oahu Virtual Speaking of Health Lecture Series. My name is Eric Barsatan, and I'm with the Physician Relations and Medical Staff Services here at the Queen's Medical Center, West Oahu. The title of today's Speaking of Health is Colonoscopy Secrets, Tips and Tricks to Make Colonoscopy Prep More Comfortable. Right on to the presentation, I'm going to ask all our viewers to be on mute. If you have any questions, please type your questions in the chat box, and our speaker will answer them at the end of our presentation. And at this time, I'm honored and privileged to introduce Dr. Traci Murakami. She's a board-certified gastroenterologist here at the Queen's Medical Center, West Oahu. She received her doctorate in medicine at the University of Hawaii, her internship and residency at Santa Clara Valley Medical Center, and her fellowship at the University of Arizona College of Medicine in Tucson. Welcome, Dr. Murakami. You may now proceed with your presentation.
Hey, how's it going, everyone? Thank you for joining me today during your lunch hour. So today I wanted to talk about colonoscopy secrets. This is based off of the Secrets series. I don't know if some of you are medical students, but we use these secrets books in question and answer format. So I kind of liked that format. Okay, so scenario, this is you. You just turned 45. You know you're supposed to get a colonoscopy, but you haven't. Here are your reasons. Number one, you've been busy. Number two, you don't have a history of cancer in your family. Number three, you haven't noticed any problems. And number four, you don't want a doctor to stick a tube up your butt. So yes, that's probably what what a lot of us out there are thinking. So what is a colonoscopy? Well, a colonoscopy is a procedure that is used to examine the inside of your large intestine, the colon, and also the rectum, using a flexible thin tube that has a light source and a camera on it. We are able to insert the tube through the O. coli and to the end of the large intestine. We use air or carbon dioxide and water to insufflate the colon, to inflate it so that we can see and look around for polyps or inflammation. And the whole colon is examined, and we look for abnormalities. During the procedure, we can take tissue samples or biopsies that we send to the lab for further analysis. If we do find polyps, we can remove them at the same time we're doing the procedure using specialized tools like biopsy forceps or smear polypectomies. They look like little lassos to remove polyps. And we really do the colonoscopy for three reasons. The first reason being for colon cancer screening, which is very important. So similar to like getting a mammogram to screen for breast cancer, we do a colonoscopy to screen for polyps, which can be precancerous growths that could eventually turn into colon cancer one day. And so we want to detect these precancerous lesions early to prevent cancer development. The second reason why someone might do a colonoscopy would be a diagnostic procedure. So this is if somebody has anemia or weight loss or abdominal pain, and we're trying to figure out, what's going on, or if they have bleeding, we want to see, okay, what's bleeding in there. So we can do a colonoscopy for diagnosis purposes. And the third reason for doing a colonoscopy would be to monitor or surveillance for patients who have certain conditions such as Crohn's disease or ulcerative colitis, where you have a chronic inflammation in the colon. And so because when you have inflammation in the colon, you're more at risk for developing cancer. So we like to bring these patients in every so often also to monitor them and monitor their disease. History, I wanted to go over a little bit about what is, the history of the colonoscope, because it's quite fascinating. Back in the 1960s to 70s, we started evaluating the colon with what was called a rigid sigmoidoscope. And it was not flexible at all. It could only look into the colon a short amount of time, and you couldn't really remove polyps. You could just really take a look, and you had to put your eye very close to the source, to the colon, to be able to see anything. In 1969, doctors William Wolf and Hiromi Shinya at the Beth Israel Medical Center in New York invented the fiber optic colonoscope based on a scope that was used to evaluate the stomach, and they thought, hey, why can't we use this to evaluate the colon? And it had a more flexible design that allowed us to get around the tiny bends and folds inside the colon. Dr. Shinya also created the polypectomy snare, which enabled removal of colon polyps. In 1983, the Welch Allen Corporation introduced the video endoscope, which allowed on-screen visualization during colonoscopies, which really revolutionized the field, because then instead of putting our eyes very close to the scope itself, we could look on a screen in high definition almost, to see the colon and to remove things. By the mid-1990s, screening recommendations for adults over age 50 were established in the US. Medicare began covering colonoscopy in 2001. In 2016, guidelines came out which suggested that adults without any risk factors should begin colon cancer screening at the age of 50. But we noticed from 2000 to 2015 that the colon cancer rates were rising, especially in the younger population. So for adults age 40 to 44, colorectal cancer incidence increased by 28%. So the US Preventative Service Task Force in 2020 actually changed their recommendation that all adults age 45 to 75 should be regularly screened. So instead of age 50 now, 45 is the new 50. Over the years, we've made a lot of improvements in the design of the colonoscope. Now it's lighter, it has smaller dials, which is more ergonomic. The image quality is very good. It's high definition 3D. There's different lighting settings that we can use to evaluate for bleeding and for polyps better. There's also AI. AI is coming onto the scene as well. And so some of the colonoscope units have the AI technology where it can kind of point out where a polyp might be and say, hey, look in this area. So that's kind of cool. We also have the ability to add certain devices onto the end of the colonoscope to make it easier to detect polyps by keeping the folds open. So you can see here, we have things called endocuffs and endorings, which attach to the end of the colonoscope and kind of just hold the folds open when we're withdrawing the scope, when we're trying to look for polyps that might be hiding behind a fold. There are a few quality indicators for colonoscopy, and this is really to ensure that we are doing a good job. When we are looking at your colon, making sure that we're taking our time, for example. So we want to make sure that we take at least minimum 6 minutes to look at your colon when we're withdrawing the colonoscope. And that's to ensure that we are taking our time to find polyps, if there are any. We also want to make sure that patients are cleaning out their colon very well. So we're also looking at the quality of the bowel preparation, how much stool is left in there, how good of a job are we doing giving patients instructions, right, for their bowel preparation. We also want to look at how often does the doctor reach the end of your colon. So the end of your colon is called the cecum. And so we want to see how often are we making it there. We should be making it there, more than 90% of the time, right? So to ensure a complete exam. Another measure that we want to look at is how well are we finding polyps, and that's called the adenoma detection rate. And so on average, we want to be finding polyps in about 30% of our patients, all comers, for first-time screening colonoscopy. We also want to make sure that we're giving patients the right recommendations for when they should get their next colonoscopy, and how often are we following the guidelines for that. So these are all, ways that we make sure we're giving high quality exams. Why is doing a colonoscopy important? Well, colorectal cancer is third most common cancer that we see. Right after, breast and lung cancer. It is the second most common cause of cancer mortality worldwide. And by 2040, the burden of colorectal cancer is projected to increase. Screening reduces the incidence of colorectal cancer and mortality through early detection and removal of the precancerous lesions. And a high quality colonoscopy is critical for long-term efficacy of colon cancer screening. So I actually found this really interesting article, which was published by one of our colleagues here, Dr. Scott Kuwata, who is part of the Queen's GI group. And he looked at data from the Hawaii Tumor Registry, and he looked at the number of cases, colon cancer cases diagnosed in Hawaii from 2000 to 2019. And he stratified them by age, gender, ethnicity, and stage. And he found that Native Hawaiians contributed disproportionately to early onset colorectal cancer and presented 5 to 10 years earlier than other ethnicities. And so, that's really important, right? We want to make sure that we're reaching that population. Early onset colorectal cancer was also increasing factor in females in Hawaii versus the males, which was kind of different than the trend that we see on the mainland. So that was another interesting finding. So I also wanted to talk about the bowel preparation, right? Because a lot of people out there are, hesitant to get a colonoscopy because of the preparation. We've heard the preparation is worse than the procedure. So there are some key steps that can help you prepare for your colonoscopy. The first thing is dietary changes. So about 2 to 3 days before your colonoscopy, you want to really cut down on high fiber foods to make the process easier. I'll get into that a little later. The day before the colonoscopy, you also want to stay on a clear liquid diet. You want to make sure that the morning and evening before your colonoscopy that you are taking your bowel cleaning medication. These bowel cleaning preparations often use a laxative that triggers bowel movements and cleans out your colon. You also want to make sure that you stay hydrated during this period and drink a lot of electrolytes, because this whole process can be very dehydrating. So you want to make sure you have adequate fluid intake. Bowel preparation is very important because we want to make sure everybody has the best chance possible for finding polyps. So we want to make sure we can see the colon, see the mucosa, and that it's not covered still with stool, because polyps can hide under the stool, especially because a lot of colon polyps are very flat and can be hard to see. And so that's why being cleaned out is very important. So there's several different kinds of bowel cleansing preparations that are available. We have the traditional bowel prep, which is drinking up to 4 liters, which is nearly a gallon of a drink, in combination with other fluids like water and juice and things like that. So I actually have a bottle here, so if you wanted to see, this is a sample of how big the container is. It's just like a gallon, milk jug. And so this type of bowel preparation, which is, you're drinking a gallon, is composed of polyethylene glycol, which is an osmotic laxative, which means it draws water into the colon and creates softer, easier to manage a stool. A lot of the bowel preparations also contain electrolytes as well. So the polyethylene glycol-based preps include Go Lightly, Miralax preparation, and Movi prep. There are also bowel preparation solutions that are sulfate-free preps, which some people like because they taste a little bit less salty. A lot of these bowel preparations taste like you're drinking salt water, so it can be a little salty. But if you ask for the sulfate-free ones, they might be a little bit more palatable. And these sulfate-free preps are called New Lightly and Tri-Light. So bowel preparations work to clean out the colon by using osmosis. So really, you're drawing in water into the colon, and the increased water in the colon is helping to soften the stool, making it looser, easier to come out. There are also lower volume preparations, and these are usually saline-based formulas that contain sodium phosphate as the primary osmotic agent instead of polyethylene glycol. And they often contain potassium and magnesium as well. The taste in these saline-based formulas tend to be a little bit more palatable, I think, to patients. And a lot of people compare them to drinking like a sports drink, like Gatorade. They also come in a pill form, which I'll get to. And they do also still require drinking half a gallon of fluid still. But instead of 4 liters, you might only have to drink 2 to 3 liters of additional fluid. Example of some lower volume preparations include Suprep, Plenpic, and Sutab, which is a tablet form. We also have what's called like a do-it-yourself bowel preparation. So this is called Miralax Bowel Prep. And instead of getting a prescription and picking up from the pharmacy, you actually can buy these ingredients yourself to make your bowel preparation at home, especially if you like Gatorade. This is an option. It's a little bit less to drink, but you do have to purchase the ingredients yourself to make it. But I just thought, it is an option for those of you that do like Gatorade, or, if you wanted to make your own prep at home, it is possible to do so. The newest bowel preparation that was approved in June of last year is called Soufflave, and it's supposed to take like a sports drink, like a lemon lime flavored sports drink. Compared to Suprep, 94% of patients did achieve a successful bowel cleansing, and patients found the taste to be very pleasant compared to Suprep. The problem with a lot of these newer bowel preparations is that it's not on formulary yet with insurance. So, if the cost is a barrier, sometimes, we can find coupons online and things like that. But a lot of times, it might not be covered by the insurance. So that is a barrier for a lot of these newer, lower volume bowel preparations. The other newer bowel preparation that came on the market, I believe in 2020, is called Sutab, and a lot of patients do like this better because they would rather swallow pills than drinking a whole bunch of fluid. It's kind of a lot of pills though. It's still 24 pills in total. You take 12 pills the night before and 12 pills the morning of your colonoscopy. A lot of patients ask, well, do I have to take all the pills all at once? No, you can take one pill with a sip of water every couple of minutes. And you still have to drink fluids though in order for the bowel preparation to work. You can't just take the pills. You still need to drink the 2 to 3 liters of fluids to allow the prep to work. Again, not all insurances will cover this as well, so we'll have to check with your insurance if it's on the formulary. A lot of the bowel preparations are what we call split prep, and you might see that. And what we mean by that is that you're going to drink half of your prep the night before the colonoscopy, and then the other half the morning of your procedure. And the reason why we do it this way is because they used to, in the past, have patients drink or finish their whole preparation the night before. But when we compared doing it that way to doing it the split way, we found that patients that have a split prep tend to be cleaner, especially in the right colon. It just that extra burst of bowel preparation kind of cleans out sort of the residual. So we do prefer split prep for our procedures. A lot of patients will ask, well, how long after you start drinking the bowel prep will you start pooping? And so typically it can take a little bit of time to work. Sometimes it can, some patients, they say they go 15 minutes right after, but for a lot of patients, it could take up to 3 hours even, for the prep to start kicking in. So give it a little time, be patient. So which prep is right for you? I know there's a lot of choices out there. The polyethylene glycol formulas tend to be the safer option for patients who have issues with fluid retention, heart failure, kidney problems. And so that is the more, I think, commonly prescribed bowel preparations, and that is the preparation we have here in the inpatient side in our hospital. We offer the polyethylene glycol, the Go Lightly formula. because it is pretty safe even for patients who have like kidney problems. Now, the saline-based bowel preparations that include the sodium phosphate salts, those ones are not safe for patients who have kidney issues. And so we try to avoid those in patients who are on dialysis, for example. The saline-based prep can also irritate the intestinal mucosa as well. So maybe not the best, for patients who have inflammation or Crohn's disease or ulcerative colitis. So again, yeah, people with heart or kidney disease may require preps that don't have that sodium phosphate or magnesium in them. Make sure to have a good discussion with your doctor, about what prep choice might be, option for you. What if you're difficult to clean out? So some patients have issues, for example, with chronic constipation. It takes them a while, maybe they only have, 2 to 3 bowel movements a week, something like that. So in order to make it easier to do the colonoscopy cleansing, we recommend to take Miralax starting the week 7 days prior to your colonoscopy. And that way we get the process started earlier. And also maybe considering doing a prolonged liquid diet. So maybe doing a liquid diet for 2 to 3 days prior to your colonoscopy procedure might be helpful, especially if you have issues with constipation. So other tips for successful bowel preparation include read your instructions. Read your instructions maybe a week or even 2 weeks before your procedure. I can't tell you how many patients maybe read the instructions the night before and go, oh, I didn't know I was supposed to do that. So make sure you try to read the instructions early because you'll have questions. You also might need to hold certain medications like blood thinners. You might have to hold before your colonoscopy procedure, as well as certain diabetes medicines, medicines like Ozempic and Wegovy. We have patients hold their dose like the week before. So really making sure you read the instructions early is very helpful. You also want to maybe rearrange your schedule so you can be at home, the day before, at least the evening before when you start drinking your bowel preparation. You want to be close to the bathroom. So you don't want to be working the night before your colonoscopy. So make sure you arrange your schedule ahead of time. Take time off from work if you need to. Also, another tip for successful preparation is your diet. So maybe 2 to 3 days before your colonoscopy, you want to start cutting out foods that are high in fiber, like raw vegetables, granola, corn, things that have a lot of fiber in it are going to hang out in your colon longer. So you want to stick to what's called a low residue diet, low fiber diet, starting 2 to 3 days before your colonoscopy. That will help a lot. You also want to make sure to try to hydrate yourself very well before your procedure. Some examples of foods that can be low in fiber include eggs, rice, salmon, chicken, and cooked vegetables, and soups. You want to make sure you're adequately prepared for your bowel preparation because patients, I feel like they always feel they're going to get really hungry and they're going to be starving, but there's a lot of options for what's called a clear liquid diet, right? So the day before your colonoscopy, breakfast, lunch, dinner, you want to stay on clear liquids, but that includes Jell-O, that includes popsicles, Italian ices, gummy bears. Gummy bears are clear liquid because when you eat them, they turn into a liquid right inside of us. So hard candy is okay as long as you stay away from the red and purple ones. Black coffee is okay. Technically, it's not a clear liquid, but we allow black coffee. Just do not add honey or cream because those are not, clear liquids. Iced tea is fine. Chicken broth, beef broth is fine. You want to also maybe think about purchasing those Crystal Light packets, the powder, peach iced tea, Kool-Aid, or orange Tang, because you can sometimes add those powders to your bowel preparation to make it taste better if you don't like the taste. Another thing that is helpful is Pedialyte or Gatorade. Drinking that can help replace your electrolytes as well while you're drinking your bowel preparation. I think they also have like liquid IV, packets as well. And don't cheat, because we will find out if people do not stay on a liquid diet the day before, we can usually tell when we're doing the colonoscopy. And a lot of times, if you're not cleaned out enough, we'll have to cancel your procedure or reschedule you sooner or bring you back sooner, for your next colonoscopy. So other tips that I find helpful when drinking the bowel preparation is you want to drink it cold. Maybe some patients like drinking it room temperature or warm, but a lot of patients find it easier to drink when it's cold. I had one patient put it in the freezer and she made like a little slushy out of it. But you want to drink it cold, and you can drink it with a chaser. So some patients are like, oh, I didn't know I could drink other clear liquids when I was drinking the bowel prep. You can. So things like white grape juice is good, apple juice, 7-Up, ginger ale. You can have a chaser ready because it has a little bit of an aftertaste. So you want to make sure you have something to chase it down with if you don't like the taste. Another tip is using a straw. So if you use a straw, you won't taste the aftertaste as much. Chewing gum between sips, if you want, that can help. I had one patient tell me that she sucked on Li Hing Mui in between drinking the solution. So I suppose that's another option, but just don't chew on the Li Hing Mui because that's not a clear liquid. You can suck on hard candy, Jolly Ranchers in between sips, but you want to really avoid red or purple colors because that can stain the colon, making it look like there could be blood or inflammation. So try to avoid red or purple liquids and foods. A lot of times we'll also add simethicone, which is like Gas X, and we'll have patients take that the night before or the morning of your colonoscopy to reduce the amount of bubbles in your colon. So sometimes that will be a part of your instructions to reduce the amount of bubbles and gas in the colon. You can also start your bowel preparation earlier in the day. So a lot of the instructions will say to start the night before at 6 p.m. You can actually start at noon if you want. If you want to start that morning, you could start the morning, the day before your colonoscopy, if you're worried that it's going to be a long time for you, hard for you to drink that much fluid. If you're worried about, if it's going to take a long time for you to clean out, you can start a little earlier if you want. Give yourself more time to drink the solution or to just avoid having to run to the toilet all night. You can also ask your doctor to give you like anti-nausea medicine. If you feel like you're really sensitive to medications, you might have, nausea. If you drink the bowel preparation, you can have Zofran on hand or some other kind of anti-nausea medicine. You can also, if you're feeling nauseous when you're drinking the prep, one tip is just to slow down the rate or how fast you're drinking the fluid. So bathroom entertainment is very important. You want to make sure you have your movies, you have your shows on your iPad. Sit yourself down on the toilet and, watch something, read a magazine, read a book, because you're going to be in your bathroom a lot, once you start drinking the bowel preparation. Wear loose clothing. You can also use a lot of times, if you're wiping a lot, your bottom can get, chaffed or a little bit irritated. So you can use Vaseline or, the butt paste and ointment. You can also use wet wipes as well or softer toilet paper. I know one tip I have is maybe dab instead of like scrape or, wiping vigorously, just kind of dab a little bit. But yeah, you want to make sure that you have things to do in the bathroom. What are some barriers to getting your colonoscopy done? Among adults age 45 to 49, 80% are not getting screened. So we want to make sure that when you turn 45, you get your colonoscopy done, because more than a third of U.S. adults are overdue for colorectal cancer screening. A lot of people just remain uninformed or maybe don't see their primary care doctors regularly. Usually it'll be your primary care doctor, right, that will recommend, hey, you're due for this. There's still a lot of, I think, fear and resistance to receiving this life-saving screening test. There are some maybe financial constraints or, geographic accessibility to getting the procedure as well. But I think one thing to remember is, throughout this process, just to stay focused on the goal, right? So one night of unpleasantness every 3 years, 5 years, 7 years, or 10 years, depending on, when you have to come back for your next colonoscopy, it's really a small price to pay, right, for preventing colon cancer or detecting it early. So how can you get your colonoscopy done, and where do you get them done? At here at the Queen's Health System. And so we have, two main campuses. We have the main Manamana campus. So we have the Kamehameha 4 endoscopy unit, which is where we do more of our sicker patients, higher risk patients, also patients in the hospital. And we also have our colon screening program in the POB3, Physician's Office Building 3. And so that's, places where we do our screening colonoscopies. Here at the West Oahu campus, we have our second floor surgical services endoscopy unit. And we just opened, as of last week, our same day surgery unit on the first floor. And today will mark 1 week that we've been open exactly. And so very exciting. And we also have a direct access colonoscopy program. And what this means is, at both campuses, we have this program. So what this means is that if you're healthy, not much medical problems, and you're due for your colonoscopy, we can schedule you even without having you coming in for a office visit. So you avoid office copays. You don't have to come in for an office consultation. We can just quickly go over with you your health history, what medications you take, and all that, and give you the instructions over the phone, send the bowel preparation to your pharmacy, and schedule you for your procedure date and time without even having to come into the office. So that is an option for your healthy patients, who are just due for their colonoscopy. You can find more information about the direct access screening program on our website. We also have our bowel prep instructions available on our website as well for patients if they forget. We do have a video available on there that goes over the bowel prep instructions. And so I wanted to talk a little bit about our same-day surgery center here. So the first day of operation was last week, June 13th. And so instead of having patients that live on the west side commute to town for their procedures, we can provide high-quality care close to home. We have multiple specialties, not just GI, that will be using the same-day surgery center. So we have urology, ophthalmology, orthopedics. There's 2 operating rooms and 3 endoscopy GI rooms down there. And the same-day surgery center is open Monday through Saturday, 6 a.m. to 6 p.m. And so I had some pictures here. You can see we also have some artwork, some nice photos that were taken by one of the GI doctors. There's the entrance, so it looks like. Those are our scope washers there. Okay, and that's it. So I can take any questions if anyone has any questions.
Okay. All right. Thank you so much, Dr. Murakami, for the great presentation. Wow. That's really some great tips there. Again, she said, don't cheat because they'll know. You don't want your appointment to be scheduled or your appointment to be rescheduled. And also, I just wish that I knew all of these tips before actually I did mine a couple years ago. So thank you so much, doctor. So right now is our question and answer portion. Again, if you have any questions, please post them on the chat box. And we do have some questions here. The first question is, does research show why colon cancer is on the rise, and why colon cancer is becoming more prevalent in younger adults?
Yes. So yes, there is ongoing research. I think some of the hypotheses that we think are going on is number one, our food that we're eating, more processed food, the advent of fast food, and also obesity. So we know that obesity is linked to colon cancer. So perhaps also the obesity epidemic is also contributing to the increased incidence in younger people as well with colon cancer. But yeah, I mean that is a good question. I do think it has to do potentially with the foods we're eating, but there could be more to it than that as well. But yeah, ongoing research is more research is going on about it.
Yeah, very good. The next question is, does one need to get a referral from a PCP to schedule one?
Yes, I think it depends on your insurance. I think some of the PPOs allow you to see a specialist without getting a referral from your PCP. So it depends on, I think, your insurance plan, because not all patients need a referral from their primary care doctor. But, a lot of times, some plans, they require the referral to the specialist from your PCP. So you might just want to check with what plan you have.
I have another question here. This person says that you turned 45 3 years ago, and so they asked the doctor to get colonoscopy. However, that physician said they're healthy. There's no family history. There's no signs, symptoms, or any sort like that. So they deferred to do it later. So what would be your advice for if a primary care physician tells that to a patient and they really want to do it now?
I would say I would ask your primary care doctor just to review the guidelines. I mean, I understand there is a little bit of controversy, I think, but I think at least most of the societies out there do agree with screening at younger age, 45 versus 50. And that is, it's rather new. So maybe some of the primary care doctors aren't aware of the updated guidelines. And also you can point out to the statistics of younger people getting, polyps and colon cancer. So, yeah. I could talk to them if you want. Yeah. There is other options though for screening as well. So, perhaps, if your primary care physician, isn't interested in ordering colonoscopy for you, you could maybe ask them, oh, hey, what about, another type of testing, like a stool-based testing to check for blood in the stool. And then if that's positive, then perhaps maybe you should get the colonoscopy. So there's other screening tests besides colonoscopy that are available to screen for colon cancer and colon polyps.
Very good. Another question is that this person took their colonoscopy about 3 years ago, and then they said that the next time they'll do it is 10 years from that date. But she feels like she needs to do it every 5 years. Would insurance cover that?
Yeah, no, I mean, usually they go by the guidelines. So I'm assuming if, her last colonoscopy, he or she last colonoscopy was normal, they might not be due yet. But if, like I said, if, there's other reasons for colonoscopy. So for example, if you develop, a change in your bowel habits, or if you have abdominal pain, blood in the stools, you could perhaps do the colonoscopy earlier if you're having symptoms, right? So we don't only do it for, screening purposes, but yeah, it might not be covered by your insurance if you're not due yet by our guidelines. But, if you have other reasons or develop other symptoms, you could do the colonoscopy sooner.
Okay, very good. Another question is Cologuard a good screening tool? I always see it on television, on the commercials. So.
Yeah. I mean, I think the best screening test is the one that gets done, right? So the Cologuard is an option, and it detects not only blood in the stool, but it also detects DNA in the stool that is associated with polyps and colon cancer. So it's kind of unique in that way. Some of the other stool-based tests just look for hemoglobin or blood in the stool, right? So it is a little bit, I would say, more maybe specific for looking for polyps or colon cancer. And it's nice because you can do it at home, right? And it's I think you have to mail it though into the company. But if it is positive, so if it does show there's stool or there's some kind of DNA detected in the stool, then you will have to get a colonoscopy as a follow-up exam, right, to that test. But yeah, the best screening test is the one that gets done, really. So I'm happy with my patients getting any testing, as long as they get the testing done.
Okay, very good. Then a person asked, how long is the colonoscopy procedure itself? Approximately, what's the timeline?
Yeah, that's a good question. So typically, I would say, an average procedure is probably maybe 10 to 15 minutes. Now, that's if everything is pretty normal, right? If you have a lot of polyps, like I've taken out, maybe 20 to 30 polyps sometimes in one setting, then obviously it's going to take a little bit longer. Also, sometimes if patients have kind of what we call tortuous or twisty colons, anatomy might be a little bit altered. It might take us a little bit longer to reach the end of the colon. Then those procedures might take longer, up to maybe an hour. So it can vary, it can range, but I would say on average, maybe 15, 20 minutes.
I see. This question is regarding if a person taking blood thinner medication or that they're diabetic, are there any concerns or risk if you are taking blood thinner medication or that you're diabetic?
Yes. Yeah, because you're staying on a liquid diet, the day before the colonoscopy, there's a risk of getting low blood sugars, right? Because you're not eating like you normally would. And so that's why usually we have to work with your primary care doctor or your endocrinologist to adjust your diabetes medicines before the colonoscopy so that your blood sugar doesn't drop too low the day before the procedure. And so that's the main thing is like, sometimes we have patients also coming in for their colonoscopy and their sugars are like super high as well. So, so it can be a little bit difficult or tricky to know, how to adjust your medications because you are not eating normally, right, the day before the procedure. And we don't want patients' sugars to be too high as well before they do their procedure. The thing about blood thinners is that, aspirin is considered okay now. You can take your aspirin before colonoscopy, but other blood thinners like, Xarelto, Plavix, Coumadin that last a little bit longer in the body, those we usually have to work, get the okay from your cardiologist or whoever is prescribing the blood thinners to hold it before the procedure. Because if we're removing a lot of polyps, we don't want patients to have, bleeding after the procedure. So post polypectomy bleeding, which is bleeding that occurs after we remove polyps, can happen because sometimes after we remove a polyp, it creates like an ulcer there. And if you resume your blood thinner, sometimes patients can bleed later on, even delayed up to maybe 2 weeks after their colonoscopy. They could present with bleeding from where the sites we took the polyps from. So that's why we do try to be aware if someone is on a blood thinner, if we're able to hold it or not before the procedure.
Thank you. And the last question I have here, actually, there's one more that came up. Why do you think Native Hawaiians are affected disproportionately early onset colorectal cancer?
Yeah, that's a good question. I think we don't know, right? Because this was just data that was collected from a database, right? So we don't know what are all the factors that contribute to it. Should that would be the next research question, right? Is why. But I think part of it, and we see this also with I think other ethnic groups, right? That like African Americans, for example, as well. I think part of it is maybe education. Part of it may be cultural. Maybe not, feeling, ashamed to get a colonoscopy. I do know people feel embarrassed sometimes, and so part of it might be, cultural as well. But I think a lot of, outreach, probably more outreach projects needs to happen, and also more education, as well. Part of it also, I think, is maybe the financial barriers, a lot of us here in Hawaii have health insurance if we're employed, right? If we're working. But that being said, I have had patients that have done their bowel preparation from shelters. Like, I have had some patients that were living in the homeless shelter that came in for their procedures. They were able to do the bowel prep. It wasn't easy, obviously, but they're able to do it. So, it is possible despite, some challenges, patients have with their living situations. But yeah, I don't know if that answers your question, but I think that's another study that has to be done probably too. What can we do to improve screening rates in certain populations? How do we do more outreach?
Okay, thank you. Another question here, and you may have answered part of it already, but the question is, are the medical providers now recommending longer intervals between colonoscopies? My wife, age 65, is having one done tomorrow, and the prior doctor who performed her last one recommended a 10 years interval, but she did have polyps removed. The current doctor performing the procedure tomorrow requested it be performed earlier due to her risk factors, and it was approved by HMSA.
Yeah, I do think I'm not sure if this will answer your question, but I know in 2019 our guidelines changed. So we used to recommend if someone had a tubular adenoma that was less than a centimeter removed, to repeat the colonoscopy in 5 years. And in 2019 they actually extended it to 7 years to come back. So there is perhaps a longer interval where back in the day before 2019 we might tell a patient, oh, you should come back in 5 years. Now we are saying come back in 7 years. So I don't know if that is what you might be referring to, but yeah, I think you have to look at the patients as a whole, right? Because not every patient fits in the guidelines. So yes, if there are certain risk factors and other factors, then perhaps you could do the colonoscopy sooner, even though the guideline is saying one thing, right? So yeah, I don't know if that answers your question though, but there was an extension in the recommendation that happened, I think, around 2019.
And this is the last question / comment. Along with colonoscopy, does prevention primarily surround a high fiber, low processed food diet?
Yes, yeah. So yes, I think what I tend to recommend for patients is to incorporate more fiber into your diet. Try to cut down on red meat if possible, because we know that in studies red meat was also associated with developing colon polyps and colon cancer. And yeah, I mean, obviously I think it's kind of a sort of a living in modern life. I know we like the convenience, right? We like having, fast food around, right? But yes, if we can cut down on preservatives, on processed foods, I think that's better for our overall health, our overall, body as well. I tell patients, also trying to maintain a healthy, body mass index, right? Healthy BMI for your height. That's probably also important too in just overall health, but also, in prevention of developing polyps and colon cancer. So, yes, those things.
All right. Yeah, that was the last question there. So, yeah, so thank you again, Dr. Murakami. And thank you for mentioning the new Same-Day Surgery Center, which is one of the initiatives as part of the expansion plan for the Queens West Oahu. It is located on the ground floor of the CSC building, which is next to the parking structure, which makes it really easy to find. And the opening of the new Same-Day Surgery Center is great news for the community, as we are now able to do more colonoscopy. And of course, the community doesn't have to wait too long anymore for an appointment. Yeah, so again, I would like to thank our speaker, Dr. Traci Murakami, our gastroenterologist here at the Queens Medical Center, West Oahu. Also like to thank all of you, our virtual audience, for joining us today. And that concludes our Speaking of Health presentation for June. Again, the Queens West Oahu Virtual Speaking of Health lecture series is the third Thursday of each month, 12 noon to 1 p.m. Please join us for next lecture, which is scheduled for Thursday, July 18th. And our speaker will be Dr. Edward Chan, who will be talking about the procedures he will be doing at the Same-Day Surgery Center. So look out for those information. So on behalf of our Vice President of Operations, Robin Kaluhelani, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queens Medical Center West Oahu Ohana, mahalo nui loa. Thank you very much for joining us today. Until next time, please take care and always be safe. Aloha.